When taking a dementia-focused medical history, we really want to focus, of course, on the cognitive changes, as well as any functional status changes. We also want to know about mood changes, behavior changes, personality changes, sleep changes, as well as any kind of motor changes. We do a thorough medication history because there are a certain number of medicines that can also impact cognitive function. And we do a thorough family and medical history, basically looking for any risk factors that might contribute to cognitive impairment. It's really common for my patients to have limited insight into their cognitive limitations or cognitive impairment. So if a patient is not bothered by this poor insight, we kind of talk about it openly during the interview. And I often acknowledge that it's normal for them not to be aware of their limitation because of their brain dysfunction. Oftentimes I reassure them, try to normalize this for them, and also for the family members and caregivers who are present. I also sometimes say to the family that it can be a blessing not to remember or not to have good insight into this disease because it can be an upsetting thing to have to come to terms with. However, sometimes patients have limited insight into their disease, and it can really be triggering for them to hear other people talk about their memory impairment or their cognitive impairment. I try to avoid certain trigger words. The word dementia is often a trigger. Memory problem is often a trigger. So sometimes I'll say, brain function. If talking about the cognitive dysfunction is just too triggering for a patient, I often collect collateral information outside of the visit. I always try to ask the patient first, how are you feeling? Is there anything bothering you today? Then I try to kind of propose to the patient, these next questions I'm going to ask to you and your loved one because it's really important for me to hear from everyone. Building rapport with patients who are confused or anxious during a visit is obviously very important and does take practice. I always want to introduce myself to the patient. I speak slowly, clearly, loudly enough that they can hear me, but not that they feel like they're being shouted at. Always sit down near the patient, try to lean in, help them to feel as comfortable as possible. If there's a caregiver available, I try to incorporate that person in the visit because that can often put a patient who is anxious or potentially uncomfortable at ease. For physical exam, I always try to start by checking radial pulses because it gives me the opportunity to kind of hold the patient's hand and make them feel reassured, also making eye contact. I try to show my patient my face so that they can see who I am and not feel like a masked stranger is coming to examine them. I always try to walk them through what I'm going to do so as not to surprise them. Always either ask or just say, I'm going to use my stethoscope to listen to your heart and show them what I'm doing so that they don't feel surprised or alarmed by any of the exam maneuvers. Sometimes we have to be creative during an exam with a patient who is agitated or anxious. If they don't want to lean forward so that I can listen to their lungs, sometimes we stand up and walk out of the room together and I can listen to their lungs while they're on the move. Also, when trying to build rapport, often I try to kind of comment about something on their person or something that I know is important to them. In order to maintain a patient-centered approach, I always ask my patients and their caregivers what their concerns are to start any visit. The most important thing is helping them address any of their issues and feeling like their issues are being addressed. As dementia disease progresses, there's often more to discuss about kind of supporting the patient through the disease and supporting caregivers through caring for their loved ones with the disease. So we naturally focus more on discussing caregiver support resources and patient support resources and focus less on kind of chronic disease management because making sure that their blood pressure is perfectly controlled or that their diabetes is at a tight target becomes less and less important as dementia becomes more and more severe.